near them. He said give them some blow-by oxygen. So putting oxygen near them would help. It wouldn't hurt them.
No, I was just scratching.
I'm sorry. Yeah.
When you're saying arrested position, it just means on the side?
Sideline. That's right. So that in case, so sometimes in the post-ictal period they throw up, exactly. They would vomit, and if they did, you wouldn't want them to aspirate because they would still be out of it. And vomiting following is common. It can be common, yeah. So that's the key. That's why that's. Neuroblastoma. Okay, neuroblastoma is the second most common solid tumor in infancy, in childhood. Okay, let's break it down. We did this with nephroblastoma, which is the most common. So neuro means it's originating where? Brain, nervous system, or in this case brain. Blast, that's right, that's baby cells, immature, from the fetal development. Oma is a tumor, a solid mass, okay? So they actually start to develop this when they're, we had a case actually like this, and when they're in utero, they develop it. It's often not caught though till they're older. And again, it's exclusive usually to infants and very young children. The case we had, she was 2 years old, I think almost 3, and she had developed this, but had been growing, you know, throughout, probably from birth, based on this type. And you know, peak incidence is usually 22 months of age. She was how old?
2.5, I think, when they discovered.
I think she was 2 years and 11 months. So she was like classically this. And the reason why it's not usual, and usually it can metastasize, 80% of the time it does. Because unfortunately, it's a little bit faster growing, and it doesn't get diagnosed right away. Why doesn't it get diagnosed right away? Well, what are signs and symptoms of a brain tumor?
Dizziness, balance issues, which little kids already have.
All those things, right? We have conversations like this too. So unfortunately, it metastasizes the bone marrow, liver, lungs. Very common. Because a lot of the cancers that metastasize always kind of metastasize to the same areas.
So it metastasizes in your utero or after that?
Usually after they're born. Yeah, but it is there, and these immature cells are there. And again, it's not something that they necessarily could see in an ultrasound or anything, because they're not as formed, but they continue to develop and form as they get older. And again, the signs and symptoms like headache, they really can't verbalize that at a young age. Dizziness, blurred vision, nausea, vomiting. I mean, eventually when it gets high, you know, the ICP gets high enough when they start to have any symptoms, you will see it. But unfortunately, they're usually older then. 65%, it does go to the liver, and then they have abdominal mass and a protuberant abdomen. So along with this, actually, this neuroblastoma, they do also have these immature cells in the abdominal area too. 65% of the time, not 100% of the time, 65% of the time. They also check abdominally, because usually their liver has a mass on it also. That will have also developed at the same time as the neuroblastoma. Again, signs...
It's the same disease though?
Correct. Same disease. The cells themselves actually are the same. And people have said to me, how could that be? And you know why? Because fetal cells, true fetal cells that start in fetal development are all the same. They're all the same. They're undifferentiated. That's right. So like that's why they say they can take a lot of these fetal cells. That's why it's so controversial with the research that goes on. But they can take a lot of fetal cells and make them into what they want. Even. You know, that's why when we talk about cord blood, stem cell research, that's where we get to. It's not metastasis, that's right. It's 65% of the time, not always, but more than half of the time. That's why they check the abdomen. In this case, they also have the same cells. When they test it and they look and they're the same. That also start to form in the abdominal area too.
So multiple primary sites.
That's right. That's absolutely right. It has multiple primary sites, abdomen and brain. Only 65% of the time though. So my point is, if an infant does get this protuberant abdomen and they notice that it's these type of cells, they go back to the brain, or if they see that they have a neuroblastoma, the next thing they will check for is the abdomen area, bless you, the abdominal area. And again, these are some of the things that will lead to the diagnosis in terms of your, in terms of the neuroblastoma. So what do we do for that? Well, treatment, just like with any cancer, depends on staging and how advanced it is. So obviously the best prognosis is when you have a stage 1 or 2. In this girl's situation, I don't think they removed all of the tumor, correct?
No, they left some.
So that's actually a poor prognosis, obviously. They cannot remove all of the tumor because it's become too advanced. If it is later where it's in many different other areas, well then what they're going to do is tumor debulking and radiation chemotherapy. So, and if they're diagnosed before 1 year, they have a better prognosis. So they do a little bit better with some low-dose chemotherapy. And actually, they've sometimes done small surgeries with low-dose chemotherapy, and they've really done very, very well. But again, it's under 1 year of age that they have the best prognosis. So it's very hard to treat sometimes.
So is there recurrence?
Well, if they can't remove all of the tumor, obviously it's just going to continue to grow over time.
I
Again,
mean, like since it's something with a child, like once they're growing older, if they did remove it all and
they have a great
there's
prognosis.
no recurrence.
That's right. That's right. Because those cells are gone if they can completely remove them. So, and again, nursing diagnoses, anybody with cancer, it's about really the pain, especially when you have a tumor that might be compressing on something, or even chemotherapy is extremely painful. Bone pain is very common in chemotherapy. Very painful medications. And so again, pain management, post-op evaluation for bleeding and infection, again, based on chemotherapy. And again, concern over airway mass and respiratory distress, a lot of times it does start to impinge on the brain stem. And can cause a lot of problems with airway and respiratory distress they have to watch for. Hydrocephalus is actually an inability of the ventricles to drain CSF properly. What causes hydrocephalus varies. Okay, it's a symptom usually of something else. It can be when infants are born very preterm. They can actually have a compression of the ventricles because they never fully formed properly, and then they can get hydrocephalus. It can be acquired hydrocephalus that can occur if somebody had a brain trauma. So if you had a trauma to a brain, like you were in a car accident, or even if you had a tumor, like let's talk about neuroblastoma maybe, that was removed but affected the ventricles of the brain, which drain the CSF, then you can get hydrocephalus. So there's two types. There's congenital, they're born with it. A lot of children with achondroplasy, the dwarfism, you might notice dwarfism, they have hydrocephalus because they do not have properly formed ventricles. And then what happens when very young children have hydrocephalus, it's kind of amazing actually, is that their skulls are still forming. You know, you have the they're still growing. They still have the fontanelles. Thank you. They still have fontanelles and all. So as their brains are growing, as they can actually accommodate, they get like this frontal bossing. You ever look at like some of the children? They have that. That's to accommodate when they have it congenitally. So what happens when you have hydrocephalus over time is that you'll get increased ICP, intracranial pressure. Okay? Older children can be a complication of something, as I mentioned. So increased ICP is ICP that's over 20 millimeters. You know, again, it's you know, ideally should be like 17, never over 20. For infants, you see things like poor feeding, irritability, bulging fontanelles, not when they're crying, just bulging even at rest. Increased head circumference, like I was mentioning, high-pitched cry, and even the sun setting sign. You know what that is? Like that doll's eye reflex that you guys probably learned. Yeah, it's called the sun setting sign or a doll's eye reflex. I don't know if you ever heard of that.
It takes an extra second.
Yeah, and then they get like you only see very little bits of their pupils from their eyes. When you lay them down, you just see the very edges of mostly you see the white of the eye. Very edges of the pupils are what you're seeing. And for older children, it's headaches, diplopia, or blurred vision, mood swings, slurred speech, papilledema. They constricted, you know, because edema in the pupils, the eyes, nausea, vomiting. And they usually tell you, report a lot of these things. So again, the therapy, the treatment is to drain the CSF. And they usually put something in called a VP shunt, or ventricular peritoneal shunt. Those who have that, it's a shunt that goes from the ventricles into their peritoneum and actually drains, because the peritoneal space is pretty big. It can accommodate a lot of fluids. And then the body will reabsorb the CSF naturally. Okay? So it's not that they have a problem creating CSF, it's a problem draining it. So they put the drain literally from the ventricles to the brain into the peritoneal space where the body will reabsorb that fluid. Okay? So when that happens, you have to watch, obviously, that there's no blockage of the VP shunt, that it doesn't get infected, because it is a surgery and they have to put it in there. And over time, it will need to be replaced. Because eventually, as the child, especially if you have an infant, because as they grow bigger, the shunt doesn't grow. So then you're going to need a bigger one, exactly. You see that? So they say usually every year to 2 years, depending on how young they are, it will need to be replaced. And again, you want to watch for blockage. So how would I know if it's blocked?
Well, the pressure will start rising.
That's right. They'll start to complain of headaches.
The circumference will increase in a very young child.
That's right. So all those things we talked about, you'll see again. So that's what you want to watch for. And infection, obviously, you'll see a rise in temperature and, you know, rise in white blood cell count. So again, those are things you want to watch for. Spina bifida. What is this?
The neural tube they did
It's
before.
opening in the early capillarities of the spinal cord, not spinal cord, but at the time, and the cord tries to come out of that hole, and it has sometimes hairs
Mm-hmm.
on it.
Very good. So there's different variations of this too. When does it start? Way in utero, that's right. And who's at risk for it? What puts fetuses at risk for it? That's right. Lack of it. That's right, lack of it, not too much of it, lack of it. So a lack of folic acid in the prenatal diet has actually been really linked to having more of this. And obviously increased maternal age is another large factor. So what they have said is that any woman of childbearing age should be taking prenatal vitamins. Whether or not she thinks she's pregnant, knows she's pregnant, definitely when she is pregnant she should be taking it. But anybody who intends on having children at some point should also take it. Because they do find that obviously your ovaries are still there, so they will still be benefiting from that. Do you know what I'm saying? So that's why that's a big prenatal vitamin. Not necessarily prenatal vitamins, but they have a woman's multivitamin for women who are childbearing age, and that has a higher level of folic acid, which is necessary. When they're pregnant, they have an even higher level of folic acid in the prenatal vitamins. I'm sure you talked about this with Mrs. Ormsby too. So again, it has to do with the development of the neural tube in utero, and it never properly closes. So when you think about the spine, you have these vertebrae, right? So in this case, when you get toward the lumbar area, you are either missing vertebra or they're not connected properly, and an outpouching occurs. And that outpouching differs in what it could be. It could be just CSF and spinal fluid. It could be some nerves in there, or it can actually be spinal cord itself in there. So it does vary. We actually had a patient who had a corrected spina bifida who was at Children's Specialized, walking, 3-year-old, like walking, running, fine, you know, right? Very, very mobile, very fine. So, but a little bit of a neurogenic bowel bladder. So sometimes, you know, there's variations on what you will